Hello, good afternoon, and my name is Navota Rillagodage, and I work as a research assistant at the Canadian Association of Road Safety Professionals, or CASP. And I'm here to welcome you today to today's webinar, which is entitled Comparison of the Number of Pedestrian and Cyclist Injuries Captured in Police Data Compared with Health Service Utilization Data in Toronto, Canada from 2016 to 2021. And we have two amazing speakers for today, which I will introduce you in just a minute. Before introducing the speakers, I would like to talk a little bit about our organization in case you're not familiar about CASP. CASP is a national nonprofit organization that is multidisciplinary, and CASP is dedicated to supporting road safety professionals in Canada and globally. Our vision is to, by following Vision Zero principles in our research and practical approaches, to achieve zero deaths and serious injuries on Canada's roads. I also wanted to mention that CASP offers free monthly webinars on various road safety topics to our members. Before I introduce our speakers, I also wanted to mention a couple of housekeeping items. First of all, we do take questions, but we address all the questions at the end of the webinar. And we ask that you submit the questions using the Q&A function, which is located at the bottom of your screen. Secondly, we invite you to respond to the post-webinar survey, which will pop up automatically as you leave the webinar. And again, the speakers will be answering those questions at the end. And now, without further ado, I would like to introduce today's speakers. We have two amazing speakers for today, and our first speaker is Dr. Linda Rothman. Dr. Linda Rothman is an associate professor at the School of Occupational and Public Health at Toronto Metropolitan University, and an adjunct scientist in child health evaluative sciences at the Hospital for Sick Children, and an associate professor status only at Dalla Lana School of Public Health, University of Toronto. Her area of expertise is inactive transportation and vulnerable road user injuries in urban environments as a public health issue. Our second speaker is Dr. Alison McPherson. Dr. Alison McPherson is a professor in the School of Kinesiology and Health Science at York University and an adjunct senior scientist at ICES. Her research is related to keeping kids active, healthy, and safe, and focuses on the prevention of childhood injuries, primarily through policies and laws designed to reduce injuries. Thank you so much. Also, some of Dr. McPherson and Dr. Rothman's recent research projects include studying the effects of the COVID-19 pandemic on road traffic volumes and collisions in Canadian cities with a social equity lens. This work includes the evaluation of new road design modifications, such as cycle tracks, reduced speed limits, and automated speed enforcement. Thank you so much again for joining us, and you have the floor, Dr. Rothman.
Okay, thank you, everybody. I don't know if you can see me, actually. Hold on. I'm going to stop. There we go. Thank you, everybody. Thank you for the introduction. We're both very happy to be here, and we're happy that you invited us to present our recent work. So we've already got the introduction, covered the title of the presentation. We're going to talk a little bit about why studying pedestrian cycling injuries are important. We all know that active transportation is a sustainable transport method. Walking and biking is not only better for personal and individual health, but it's also much better for the environment in terms of emissions and climate change and congestions on our city streets. One of the things that we have been very focused on most recently in our research is active transportation as an equity issue. People who can't afford to have a car have few other choices other than walking and frequently now biking. And also people who are not able to drive have few other choices other than walking and biking. However, our previous research has shown that people in more marginalized areas or with different equity needs are more risk of vulnerable road user injuries. Our research and a lot of other research has shown that reducing speed, separated bike lanes, and other changes to the built environment on the roadways reduce the number of vulnerable road user collisions, injuries, and deaths. We've also found in some of our work in the City of Toronto previously that there has been less road safety features, for example, traffic calming in more deprived areas within our city. As the City of Toronto becomes more and more focused on their Vision Zero approach, which is working towards zero fatalities and severe injuries, and with more of a focus on the built environment and not so much on individual behavior, we have found that through some of our work, we've engaged in a lot of conversations about how road safety features should be distributed in terms of equity and in terms of need. The Vision Zero approach has worked in many other cities, including in Nordic countries, New York, and others. And again, Vision Zero is a very data-driven approach. In other words, where you focus your interventions on where it's needed the most. So that is what started us on this journey, because we recently had a CIHR grant to look at trends and collisions and injuries in the City of Toronto and 3 other Canadian cities. But also we were looking at evaluating.
Sorry, Linda, sorry. Looks like your audio is cutting off.
I'm not really sure why. Hold on. Can you hear me?
Yes, it's better now. Thank you.
I didn't do anything. I hope it's okay. Yeah, so our new CHR grant was looking at trends during COVID-19 of vulnerable road user injuries, but we were also looking at evaluating some of the infrastructure that went in around pedestrian and cycling as a result of Vision Zero, as a result of the COVID-19 pandemic. Things like road safety features and automated speed enforcement. So we really started to think that we needed to seriously consider how good our data actually is that we tend to use. So the objective of our study was to compare the number of pedestrian and cyclist injuries captured in police data with health service utilization data in Toronto 2016 to 2021. As traditionally we have been really focused on using the police reported data for our evaluation studies and also for our trend studies, because the police reported data actually has locations of where things happen, where the collisions occur, whereas the health service utilization data doesn't. So our team has worked with the City of Toronto on numerous studies. Many of them are related to safety in school zones, but we've kind of expanded into other areas now as well. Studies in other parts of the world have noted the underrepresentation of cyclists and pedestrians in police data, so we wanted to look a little more closely at that. The thing about police data is it's open access and it's readily shared, and as I mentioned previously, it actually has the location of the collision, which makes it easier and better to use in terms of when you're evaluating some type of road safety infrastructure. And we also wanted to have a bit of a lens of what happened during the COVID-19 pandemic in terms of the patterns of vulnerable road user injuries. We used a process at ICES called the AHRQ process. And we used it as an opportunity to capture the health services burden of cyclist and pedestrian injuries. And according to the Ministry of Health, an applied health research question, AHRQ, is a question posed by a health system policymaker or provider in order to obtain research evidence to inform planning, policy, and program development that will benefit the entire Ontario health system. So in other words, the AHRQ process actually facilitates some of the health policymakers or providers access to some data that they usually wouldn't have in terms of health utilization data. So we followed the steps to make an AHRQ request, and the City of Toronto had to put that in, transportation services, so we assisted them with that. The team at ICS was really helpful in defining what consisted of an injury in Toronto. using the postal codes of both the treating hospital and the injured person. And the ICES analysts help us refine the direct definitions so that we are most likely to capture the cyclists and pedestrians of interest. And I have to say, thank you to Dr. McPherson, because there's a lot of back and forth in all of this, and it takes a lot of time to get the data actually correct. We had to have ICD-10 CA codes that identified them as cyclists and pedestrians, and that's the international standard for health services data coding. The coding actually allowed us to differentiate between cyclists hit by a car and not hit by a car, and that's an important distinction that we will continue to make throughout this presentation. It included only hospitals with an M postal code, in other words, the City of Toronto, and patients with a home address with an M postal code or an L postal code from nearby suburbs. And that's to exclude visitors to Toronto or seriously injured cyclists who are mountain biking elsewhere. And I'll turn it over to Dr. McPherson.
Thank you, Linda. So I guess we'll start with the health services data. And so what did we find? So we looked at both emergent. Oh, can everybody hear me okay? I know Linda's volume was a little iffy at the beginning.
Yes, we can hear you fine. Yeah.
Great, thanks. So the health services data included emergency department visits and hospitalizations, and the police reported data was just reported by the police. So we had, for cyclists, over 30,000 emergency department visits over the course of the study, and 87% of those did not include did not involve being hit by a motor vehicle, whereas about 13% were hit by a motor vehicle. And there were about 2,300 hospitalizations. And interestingly, 81% of those did not involve a motor vehicle and 19% did. And this is in comparison to the 2,362 police reported collisions for cyclists. Next slide, Linda. And for pedestrians, there were almost 10,000 emergency department visits and over 2,000 hospitalizations for pedestrian injuries. And there were 5,723 police-reported pedestrian incidents over the same period. So epidemiologists love graphs, and Linda and I are both epidemiologists, so there's a lot of graphs in our presentations. So this graph shows all of the bicycle-related injuries, which includes those hit by a car and those not hit by a car, comparing police data and emergency department data only, so no hospitalizations in this. And you can see that if you look at the trend over time from 2016 to 2021, there's a drop, according to police data, that the numbers went down, not substantially, but they did go down. Whereas if you look at emergency department visits, the numbers went up. And over time, generally, police data captured about 8% of emergency department visits for cyclists. And if we look at cyclist motor vehicle injuries captured by the police in ED visits, so these are cyclists who were hit by a car, the police data captured about 58% of cyclist MVCs. And what's quite encouraging, at least to me, is that the number of cyclist motor vehicle injuries has gone down using both data sources from 2016 to 2021. So we'll move on to our pedestrian injuries. And we can see that the police data captured about 54% of pedestrian injuries. And again, here we see a decrease in the number of both emergency department visits and police-reported pedestrian injuries, which is quite encouraging, considering the Vision Zero approach by the City of Toronto. It seems, at least in part, to be working to reduce injuries. So, as Linda mentioned in the introduction, one of the things that's really lacking in the scientific literature is that differentiation between those cyclists who were hit by a car and cyclists who were not hit by a car. So this chart shows the non-motor vehicle ED visits in the light blue and the motor vehicle collision ED visits in the darker blue. So the trends over time show that there has been an increase in non-motor vehicle collisions for cyclists and a decrease in motor vehicle collisions, which again is quite encouraging, but it also prompts some questions about what's happening in the built environment, that the non-motor vehicle collisions are going up and the motor vehicle collisions are going down. So we were also really interested in capturing more severe injuries. And those of you who use police data will know that the KSI is police code for killed or seriously injured. And that's defined by the police at the scene. And then the DAD is the Discharge Abstract Database, which is the Canadian Institute for Health Information's database of hospitalized patients. So all of these patients who are included in the DAD had to spend at least one night in the hospital. So here we can see that the police KSI data, so only the killed and seriously injured data, captured about 10.1% of all hospitalizations. And one of the definitions for being defined as KSI is needing health services, so having to go to the emergency department. So even for those more seriously injured, they're not captured all that well in the police data for cyclists. And this is the cyclist MVC police data, so cyclists who were hit by cars. And you can see for cyclists hit by cars, the data capture is much better. They captured about 53.2% of hospitalizations. And this is the same data, the KSI versus the DAD for pedestrian. And the police KSI data captured about 48.2% of hospitalizations. And like the other data for the emergency department visits, it's quite encouraging to see a downward trend in the number of pedestrian injuries in this data as well. So this is an infographic that ICES developed for us to share the results generally. So they pick up the key findings, they talk about the implications and a little bit of the methodology. So these our partners have found very helpful, and our media partners. Linda, if we go on to the next slide. We're very, very interested in the findings, and it was reported extensively in Canada, including in French media, Radio-Canada, and it was also reported around the world, including in places like Malaysia, a lot of interest in the US. And I think that it's really interesting that people are very keen on finding out more about this. And one of the things that I just wanted to point out about this slide is we were pretty careful to not blame the police because their data has a completely different purpose. But you really can't control the message, because you can see on the top right, according to police reports, cyclists are failing. Here is the proof. And that wasn't the message we wanted to get out at all, but we can only do so much about how to control it. So next one, Linda. So some of our strengths, we thought, were the study used population-based data to capture health service utilization for cyclist and pedestrian injuries. And our belief is that this is really much better able to demonstrate the true burden of injury rather than using police data alone. Some of the limitations is that we were not able to link the two data sets. So we had to compare them, but we couldn't link them. So we're not sure if there's variability in the data sets due to age, sex, socioeconomic status, marginalization, etc. And that would be really, really helpful to know, who's in police services data, but also who's not in police services data. And included in this is we were not able to understand systemic differences due to things like race, prior experience with the healthcare system, etc. And you can imagine that in some communities in Toronto and around the world, people might be more hesitant to call the police for a bicycle-related injury or pedestrian-related injury. And if we really want to move towards Vision Zero and true prevention, we need to try and get a better handle on that. But the data is just not there yet. So the study is not generalizable beyond Toronto, and I think that's really, really important. This is a Toronto-centric study because that's where we had the police data, that's where we had the relationships, and it was the city of Toronto that asked for this data. So you can imagine that there might be findings that are quite different in other jurisdictions, but because we had the police data and the health services data, this is a study that would be reproducible in other jurisdictions. So some of our conclusions, the number of cyclist and pedestrian injuries captured using police reported data was substantially lower than the ED and hospitalization administrative data. So police reported data represented about 8% of all cyclist injuries. So that's not a very good measure. It was better for the cyclist motor vehicle collisions, but still only approximately 50%. And it was a better capture of hospitalizations, but only about 10% of all cyclist serious injuries and about 53% of cyclist motor vehicle collision injuries. So police data remains important to capture geographic location for targeted interventions. Linda mentioned that. You know, we have to have an idea of where these injuries are happening, and there's no way to get that from health services data. But I think this study really highlights the need for a more comprehensive approach to using different data to measure the burden of cycling and pedestrian injuries. So what does all this mean for the City of Toronto, for us as researchers, for ICES? I think our number one important finding is that data linkage would be the ideal way to move forward, to have a better understanding of who is captured and not captured in the data. And I think this is definitely true for cycling and pedestrian injuries, but I think you could extend it beyond to other types of injuries. Whereas if you could link, you know, WSIB data and health services data, et cetera, I think there's a great potential for trying to really understand the burden of injury in different populations and which injuries are captured in which data sets. The AHRQ process was key to being able to do this study. And Linda described what it was, the Applied Health Research Question. But this is it's a research institute at ICES, and they did all of this data. The whole database was given to us for free because this is funded by the Ontario Ministry of Health. So that's a really, really important thing. And also the analysts at ICES know this data inside and out. They know all the strengths, they know all the limitations. They were so helpful in defining what we were looking at to try and make sure that we captured cyclists who are from Toronto, riding in Toronto, and not tourists, for example, who didn't know the streets. It really was trying to capture Torontonians in Toronto. So the results of this study will and have directly informed policy in the City of Toronto in terms of how they plan the streets. I think the major finding that was particularly helpful to them was the finding about cyclists who were not hit by cars and the importance of trying to make the built environment off roads and on roads, but like places where cycling lanes are separated can still have injuries if there's problems with the infrastructure, including things like streetcar tracks and grates. So that was a really important finding. And then subsequent to presenting these findings, 2 other regions initiated AHRQ requests for their own planning purposes, which is really great because ICES wants the AHRQ to be used and to be directly applicable to cities and other policymakers. And a lot of this really is around health services data and directly like health problems such as concussions and other things. So it's really nice to see this spreading out to transport planning and to injury prevention of road safety. And the other thing is it brought attention to the need for different data approaches. That using police data is, as Linda mentioned, fantastic. It captures what it's supposed to capture, but it doesn't capture everything. And that's an important thing to note. So I think I really want to acknowledge CIHR for funding the study, the Canadian Institutes of Health Research. And our co-authors on the study, Brandon and Rafiq, are from ICES, and they are amazing with the data there. Andrew Howard, who's an orthopedic surgeon at the Hospital for Sick Children and also an ICES senior adjunct scientist. Anne Harris from Toronto Metropolitan University, and Seema, who was a postdoctoral fellow at Toronto Metropolitan University, and Jesse Coleman, who was the person who was responsible for all of this from the City of Toronto. And I see we have lots of questions, so thank you. And Linda, you want me to take a first stab at the questions, right? And then you'll jump in? Okay. Okay. Oh, great question. So it says, thanks for the presentation, really interesting. Did you have the chance to relate mobility habits data with the injury data? In 2020 and 2021, decrease in car trips, increase of active transportation as a physical activity and leisure. Could it explain the trend observed in 2020-21? More injuries without a motor vehicle and less with a motor vehicle? I think that's a great question. I think that's probably a big part of it. We didn't have a way to measure exposure in this study, but I think that that would be our hypothesis, that more people were cycling and walking. But it doesn't explain the downward trends in the pedestrians because people were walking. So I think it's probably a combination of things. Linda, did you want to add to that?
I also, yeah, in terms of the pandemic, I mean, we do know that cycling did increase quite a bit, both for leisure and also I think just for getting around. And probably there was quite a few people who weren't used to riding a bike, who started riding a bike because all the bike sales disappeared basically. So that's one issue that's interesting. But you know, you wonder also if some of those injuries happened on some of the multi-use paths. I don't know how many people rode bikes along ravine paths and things like that. May not necessarily have happened right on the roadway, but may have happened in mountain bike. Not mountain biking down the Front River. I think it probably would have, but also things just along the pathways as well. There's a lot more cycling traffic during the pandemic, initial years and continuing onwards.
Great. The next question is, I've heard about previous data showing that crashes supposedly without motor vehicle involved actually still had some kind of interaction with a motor vehicle driver. How reliable is the 87% figure without involved for cyclist crashes? That's a great question. So for the health services data, we have to rely on the medical chart. So the injured cyclist had to tell people what happened, and then it had to have gotten into the chart, and then it had to be coded that way. So I would say it's not 100% reliable because it does depend on, first of all, the patient disclosing that that was the mechanism of injury, and second of all, the attending health services folks to make sure that that got documented in the chart. If it's documented in the chart, it's accurate. So I would say it's probably with a motor vehicle involved is probably an underestimate of the true number of collisions involving a motor vehicle. Linda?
Okay, that's good. Thank you.
Okay. If a cyclist is injured when they are struck by a door being opened by a parked vehicle, would you count this as a cycling injury that did not involve a motor vehicle? I think it's the same answer to the question above. If somebody reports that they were doored, then it would be counted as a motor vehicle collision because the thing that they bumped into was in fact a motor vehicle. But again, it relies on both the cyclist and the hospital staff documenting that in the chart, in the emergency department or when they're admitted. So.
But also in terms of the police reported data, there are codes for that now, and whether or not the police are actually called all the time when somebody's doored, but they are supposed to, if somebody's hurt or badly hurt with a dooring incident, be called, and there is a code for it in the police reported data.
Okay. Given that only 8% of cycling crashes are captured by police data, can we assume that these vulnerable users may have a hard time being compensated for their injuries? Oh, I'm afraid I don't know anything about the insurance compensation. Like motor vehicle. Linda, do you? I don't know anything about that realm of this.
I don't know if there needs to be a police report for something like that or not. I don't know. I'm sorry.
Yeah, no, I don't either. How do you consider KSI reliability during the COVID pandemic, as police data have been impacted during that period? I'm not sure I understand that question. Linda, do you want to talk
Yeah,
about the KSI?
I think it might be referring to police attending collisions. The workforce was, things were different during COVID, whether police officers are off sick or things are different. But I do think we could be quite confident KSI are the most severe injuries. And whether or not they're attending some of the more mild ones, probably there's a lot of differences over COVID. But I think that the KSI probably pretty confident that if somebody was severely injured or killed, that there would have been a police attending a report. I hope that answers the question.
Linda, there was also a change, right, in the way in what police were instructed to respond to. Do you want to talk about that?
That was before I don't remember what year it was, but there was a change way before COVID that police did not have to attend some of the more minor collisions. But again, if you're focused on KSIs, it should still be static all the way through the reporting.
But I guess the point is the police have to be there to declare it a KSI. So clearly they do miss some of them, as we can see in our data, because patients who are hospitalized, there were more patients hospitalized than categorized as KSI. So. And the next question is, are police required to attend a crash if it doesn't include a motor vehicle? No. That's one of the reasons why there's such a big discrepancy between in the police data for non-MVC crashes. And I mean, I don't think it would ever be feasible to expect the police to attend all of those things that happen on the bike lanes and stuff like that. But I think the reason why we included those in this study was to show that the burden of injury goes beyond what the police actually capture and well beyond what they could even potentially capture if this was their number one job, which it's not. I think it's really, really important to remind people that the police's job is to respond to incidents. It's not to collect data on every single thing that happens. So our study is not intended to be critical of the police and say they're not doing their job. It's more to say police data are one aspect of gathering information on what happens to cyclists and pedestrians on our roads. But there are other sources of data that give a more complete picture because they're collected for a different purpose.
Alison, there's a question in the chat from Nico. Do you want me to read it?
Sure.
Do you recommend other municipalities to pursue a similar process? My sense is the results will be similar. How else might the findings inform Vision Zero related municipal policy? And he's from Guelph.
Oh, yes. Well, I think if you have a kind of a defined boundary that you're looking at, because the other municipalities that have AHRQ requests in currently are Peel, which is a region, not a municipality, and Niagara, which is also a region. So the AHRQ can help municipalities understand the breadth and depth of the burden on their streets. I think it would be great if Guelph did that. Guelph's already, I think, very progressive in their Vision Zero policy and in their efforts to improve road safety in their city. So I don't think it would hurt to find out. I think the thing that I'm struggling a lot with is the more rural areas. and how would we capture, I mean, in lots of rural municipalities, it's the Ontario Provincial Police who would respond. And I think it's harder to get a definition. And I think some of both the road safety issues and the relationship with the police issues can be quite different. When I gave a similar presentation, somebody from Sudbury was talking about the relationship between people from Indigenous communities and the police in parts of Ontario, and that it's highly unlikely that an Indigenous person would call the police for a bicycle-related or a pedestrian-related injury because of the history of racism. So I think the results are somewhat generalizable to large urban environments, but I think it would be really interesting to see how this played out otherwise in other areas and in other places. So yeah, if you want an AHRQ for Guelph, jump on it.
Also, can you comment on doing the AHRQ to get the hospital data versus going to the public health units within your city? Because some of them have access to similar data or the same data.
I mean, that's, I forget what that data is called, but that would definitely be one way to move forward if they have analysts who can tease this all out. I mean, it's not that hard to figure out the different codes, and I guess public health units would be our experts as well. The only thing would be, I'm not sure if they have like the level of postal code that ICES would have to be able to capture people who aren't just visiting. But probably, but yeah, that would be probably a good place to start.
Can I just a little summary comment as well? I just wanted to say that we do rely on police reported data to plan and evaluate infrastructure in the cities. And we have to use police reported data because it's the only one, as I said, has the location of where something's happened, which, as you can imagine, might be a problem because maybe we're systematically not picking up something happening that needs to be fixed in a different part of the city than we're actually addressing. So it's something that's really quite important to consider. We are using data that is only representing at best half of the people showing up in hospitals, and we're basing our planning around it. We do talk a little bit about maybe using integrating some of the first responders data into some of this, but again, those will be the most severely injured, and we haven't. I think Dr. McPherson has done a bit of work on that, but it's another data source that we could look a little bit more into.
Yeah.
There's another chat question.
I think it's a comment, but I think it's a really important one.
Okay. In other cities, e.g. Ottawa, Sudbury, data may need to be collected on land use or posted speed limit. This might help distinguish crashes that occur in urban versus rural settings within city limits.
Yeah, I agree 100%. And I think that the data sources might have to be different because my understanding, and I'm not an expert in any way, but some of the city is OPP jurisdiction, like the more rural areas are OPP jurisdiction, whereas the city proper would only be the city jurisdiction. And I think, yeah, land use, posted speed limit, all of those things are so important. Response time. Yeah. Yeah, for sure. This isn't the last research study we're going to have to do on this.
And again, like the hospitals would not even have that data because they don't collect the collision location data. It would be just the residence, the place of residence of the individual that was injured. Anybody else or anything else?
Comments, suggestions are always welcome too. I don't either, no.
Thank you so much, Dr. McPherson and Dr. Ahmed, for this excellent presentation. I did have one question myself. I'm not sure if it's feasible, but is there any way we can look into the breakdown of the collision frequencies between the two sources. For example, collisions associated with different hazards, for example, it could be weather conditions, cyclist injuries and pedestrian injuries that happen during adverse weather conditions. And we see if there's a difference between these different collision factors and the sources. I'm not sure if it's feasible because I'm not sure if the hospitals collect these type of data associated with collisions. I was just wondering if that's feasible.
So they don't currently, really, it's just the coding based
Right.
on the chart. But I know, for example, at Sick Kids, they've started using artificial intelligence, AI, to look at things related to injury in their hospital charts as part of the Canadian Hospitals Injury Reporting and Prevention Program. So that includes a narrative. And so if we had access to AI from the charts, from what the triage nurse, the attending physician, or whoever takes the patient's history, that it could be potential to do that in the future. And I think that that would be great, because then, you know, if AI could sort of go through those and say, oh, there's a grate, oh, there's a streetcar track, oh, there's snowy weather, you know, listed as potentially the cause. But right now, the best we could do would be to look back through weather records, for example, and see, you know, rain, snow, freezing rain, and look at the injuries. But there again, you know, cyclists are probably less likely to cycle in adverse conditions. It would probably be those that rely on their bicycle for commuting and things like that. So there's a lot of factors that would be pretty difficult to tease out.
Thank you so much. We don't have any other questions. So if you have any questions, please put it in the Q&A function, or you can also use the chat function at this point. If you have any comments about the presentation, you can put it in the chat function. Okay, I think.
Just a quick note, there is a published paper in injury prevention for the study with the same title, if anybody wants to look at it. It's open access.
Yeah, it's open access, so anybody can have access to that if you want more details about any of this. I think we were quite careful to put a lot of details in the methods section there, so that if anybody wanted to do a similar study, they could reproduce it quite easily.
Okay, thank you so much. Thank you again for the amazing webinar. It's very interesting and a lot of information presented. And thank you for all the attendees for attending this webinar. Our next webinar will be in late March, and we will be advertising the next March webinar pretty soon. So thanks again, and have a nice weekend, and have a good rest of the day.
You too. Thanks.